right, well, good morning, everybody. Thanks for joining today. Part of what is a real spectacular curriculum ongoing by Rayos Contra Castor on the topic of hypofractionation. And today I'll be speaking about hypofractionation for high-grade glioma. And so I'll start just with an overview. The learning objectives for today, we'll talk about the general management of patients with high-grade glioma as a segue to identify clinical indications for hypofractionated approaches. We'll delineate the pathway that one undertakes to implement hypofractionation for high-grade gliomas in local clinical practice. And then we'll describe specific planning considerations for hypofractionated radiotherapy for patients with high-grade gliomas. The outline will include a brief overview of management of high-grade glioma, the rationale for hypofractionation, specific considerations for implementing hypofractionation, and a few example cases employing hypofractionation. I also would like to frame the outline as the whys when under something novel, perhaps to a practice. To understand the why as to why hypofractionate, we'll talk about the radiobiology. The who or where, when, those are all the same in that who may benefit from hypofractionation, what is the appropriate patient selection, and then what is needed to implement hypofractionation, more so on the technical and treatment planning side. So many discussion points to consider. So I'll start with the overview of the management of high-grade glioma, which is going to be very familiar, I suspect, to most folks participating in this talk. So by way of a broad background, high-grade gliomas are the most common malignant brain tumor in adults. They're also fairly frequent in the pediatric patient population as well, in terms of CNS tumors. A key characteristic, which will be echoed throughout this talk, is that they're highly infiltrative tumors. So the nature of these tumors is that they extend beyond what may appear radiographically as a discrete tumor and actually have infiltrative component into normal, healthy brain parenchyma. The standard of care therapy includes maximum safe resection, chemoradiation, and continued adjuvant chemotherapy. And more recently, the inclusion of tumor treating fields in select patients. And of course, clinical trials remain a mainstay for this patient population. Now, despite all of those interdisciplinary interventions with really high quality surgery, radiation, and chemotherapy, the overall survival for most patients, unfortunately, remains poor, and especially for the highest grade tumors on the order of. So among the clinical features of high-grade glioma, again, they are infiltrative tumors. In terms of the histopathology, they're pleomorphic, hypercellular. Pathologists can observe visible mitotic figures representing a fairly high proliferation index. They can see vascular development, microvascular hyperplasia, and the characteristic of pseudopalisading necrosis, and that's shown here on some of these histopathology micrographs. From an imaging perspective, there are some common imaging features, which is that for the high-grade gliomas, we'll often see contrast enhancements on T1 post-gadolinium imaging, and you can see that in this representative image with what appears to be two foci of ring-enhancing, contrast-enhancing lesions present in the left temporal lobe of this patient. But beyond that, when you look at the T2 flare hyperintensity, which can represent both edema reactive to the tumor, but also infiltrative microscopic disease, I show that by the yellow arrows, you can see that the T2 flare hyperintensity signal looks a little bit more bright as compared to the regional brain parenchyma, extends beyond that contrast enhancing component and into essentially what may be mostly normal, healthy brain tissue. And so that creates challenges when we're trying to treat and target the extent of disease, and also challenges when we consider hypofractionation. Now, I think it's important to recognize some of the updates that have happened in the past several years with regard to how we classify these tumors. And so with the new 2021 WHO classification, we identified these tumors not just on a continuum of histopathologic features that you see under a microscope, but now more molecular features. And that's refined how we classify these. So when we look at higher grade gliomas, we're not just looking at their histopathologic features, of course, but we're looking at molecular gene status. So things like IDH1 status, whether it's present intact or in a mutant form. We can also look at H mutation status in pediatric patients that's representative of diffuse midline gliomas. And this has evolved as we've done the studies to show that when we molecularly classify patients with high-grade gliomas undergoing treatments, whether it's a traditionally grade 4 glioblastoma or grade 3 anaplastic astrocytoma, you can see how the survival curves diverge significantly based upon this mutation status. And of course, in terms of our classification, the classification should first and foremost drive prognosis as well as predictive response to therapy. So that has borne forth the new subtypes. And you can see here some of the characteristic mutations that we're looking at within these various tumor types. Now, with regard to therapy, and specifically radiotherapy, following maximum safe resection, which has been a mainstay of therapy for a number of decades, we have arrived slowly but surely at what is the current standard of care for these tumors. And notably, that is recognizing the fact that these tumors tend to be fairly radiation resistant and that they have a high rate of recurrence. And so some of the seminal studies done now back in the 70s very thoughtfully demonstrated that with dose escalation, and of course this is in the pre-temozolomide era, and in some cases in the pre-chemotherapy era, but dose escalations led to improved outcomes. I mean, this is similar to what has been seen in prostates and in lung tumors as well, as we have the technological ability to deliver these higher doses safely on target with good image guidance. We've been able to achieve this without increasing rates of toxicity. And ultimately, we arrived at a dose of 6,000 rads or 60 gray to treat these tumors. Subsequent studies that were performed in this era using doses above 60 gray, up to 75 gray, did not show any improved survival benefit, but actually showed an increased risk of radiation-related brain injury. Even though the prognosis of these patients is poor, the toxicity could manifest in both the acute and subacute setting. And so this really was a contraindication for therapy. So with regard to the actual target delineation, I have a quick Zoom poll before I speak about this. So here's a Zoom poll, and I would ask the group, and again, I apologize that the contours are relatively small in color, or small in size, but for a given patient here who has a high-grade glioma, I would ask the group which set of contours may be most appropriate for a patient that had, as you see in this right temporal region, a near total resection.
So the participants, you should be seeing our simple question now. If you have any trouble, you can send your answer in the chat and we can see them here also.
I'll give it just a few more seconds to give
great.
folks an opportunity.
Yes, great. Do you have more participants? And if you don't see the simple option, just send it in the chat.
And I love the responses thus far.
Yes. I think it's a great question too, then. And I see that the answers are really divided. So we can wait just a few more seconds and go ahead to see lots of answers coming on the chat. AD, it's the more common. Okay, do you want to see the results, Dr. Braunstein?
Sure.
Okay, great.
Okay, there we go. You can see it there. Mixed, really split nicely across the board. And that's wonderful. That's what I would like to see. And that's why we put it in this question. Sometimes questions have a very clear right answer, sometimes not. Now, I would say that most of those answers are certainly within the scope of reason. And especially if you think about how we would treat in the 3D era. I'll say a few things about this and then talk about even how there's contention among experts. So when we're thinking about the contours for high-grade glioma, we want to include, of course, the gross disease in the surgical cavity. And the disease includes both the post-gadolinium contrast-enhancing disease on postoperative imaging, as well as T2 flare hyperintensity disease. Sometimes it's difficult to distinguish on the T2 hyperintense signal, whether that represents perhaps post-surgical edema versus true tumor infiltration. And then, as I will say, if there's uncertainty, likely more is better because you don't want to undertreat disease. One of the things that can help here is the use of imaging in the preoperative setting to look at what was the extent of infiltrative disease in the preoperative setting and compare that to the postoperative, because there will be some regional edema that will appear as T2 hyperintense. Now, going through each of these on A, it's a little generous. Sometimes it's hard to distinguish whether that region in the right anterior temporal tip is truly hyperintense or not. Again, that I think is challenging. But you can also see that with regard to the CTV in blue, that it's fairly generous. These extend usually 1 to 2 centimeters. I'll show you the slide in a moment with that information, but it generally respects anatomic boundaries. So we wouldn't, if the lesion is present in the temporal cerebrum, we wouldn't put that dose, let's say, as you can see, into the vermis or into the contralateral posterior temporal horn. That would not happen routinely. So it's a little bit too generous. A. B is a little bit too stingy in terms of the contours, especially the CTV being just a few millimeters on top of the GTV. And with C, you can see, again, not respecting anatomic boundaries and putting the CTV into the cerebellar vermis, as shown by Dr. Lee. And then also, you can see that in D, that's essentially what we would do in practice here, understanding both the pre and postoperative imaging, extent of the T2 hyperintensity attributable to disease. So the GTV representing just the tumor bed plus T2 hyperintensity, but then having a CTV that extends, respecting anatomic boundaries, about 1.5 to 2 centimeters, and then a small PTV on top of that if you're doing a robust image guidance. So just to review that here, the standard target delineation includes the gross target volume, which is the T1 post-contrast on the post-op, the postoperative cavity, as well as the T2 flare hyperintensity that you can confidently attribute to disease, and then a planning target value on top of that. So the GTV to CTV expansion is 1 to 2 centimeters, and then the PTV usually another 3 to 5 millimeters. But recognize for this example here from this nice paper is that for a patient who has, let's say, a left frontal lobe lesion, even after a gross total resection, the actual target volume can be quite large. And again, that has consequences in terms of how we think about hypofractionation, because we're treating a fairly large target volume. And of course, again, remember that disease infiltration generally respects natural anatomic boundaries. So in this case of what is a lateralized left frontal lesion, you wouldn't necessarily bring the contour volume across the falcine dura into the right side. Now, if it extends close to the corpus callosum and that's a pathway extension, then you might do
Dr. Braunstein, and we have a question here from one of our participants, and is, do you or would you change something in your contouring if you only had a biopsy, or you had, I don't know, a gross a resection that wasn't an R0 type of resection? Hi, Dr. Braunstein, can you hear me?
Holding very still.
Yes, I think he'll be joining us again. We are going to ask you for a few minutes while we get Dr. Braunstein back.
The question was so hard that he ran away. He says he's rejoining.
Sí, pasa. Vamos a darle unos minutos al Dr. Braunstein para volver a unirse con nosotros. Les pedimos entonces unos minutos mientras se une nuevamente. ¿Listo? Y continuamos con la presentación. Gracias. Y recuerden que pueden ir enviando las preguntas en el chat, y si alguno desea levantar la mano y participar, pues también puede hacerle preguntas directamente a nuestro educador de hoy.
I thought that question was so good. Like, right off the bat, we already see there's room for improving how we standardize things. The other thing I would just share from my own experience, because I have been a resident working with Dr. Braunstein, is that when you're evaluating the anatomic boundaries, you have to look in all of the different planes. So look on the sagittal view, look on the coronal view. And it's really hard because here we do a 2 centimeter CTV expansion. And so sometimes I have to look and I have to use a ruler to see, okay, what is 2 centimeters in this direction? So you can't just look at the axial slices when you're doing your 2 centimeter expansion. And then you have to look at the anatomic boundaries every way that you're aiming. And sometimes it gets to a place where it's getting just below the falcine dura, and then you do have to cover the area where the parenchyma connects to prevent spread across the midline. So yeah, the anterior commissure is one route that you want to make sure you don't miss.
Hi, Dr. Braunstein, welcome back. So you should be able to share your screen again. And
Thanks,
Ben was
everyone.
telling us a few tips that he has learned from you as a resident.
Excellent. Well, thank you. I'm so sorry about the Wi-Fi instability,
It's
but here we
okay.
are.
Were you
And
able to hear my question?
no, please ask the
Okay, so
question.
one
Yeah.
of the questions we had from the participants was that if you have a marginal resection or just a biopsy, or you know that there is a residual tumor, would you change or consider changing your target volumes?
Oh, that's a great question. So, and that happens with some frequency, and that's where I think as radiation oncologists, we have an important role because the surgeons can be quite limited, even with the best surgical techniques in terms of the extent of resection, they can do more harm than good. So it's very common for patients to have subtotal resections or near total resections, or in some cases biopsy only, essentially, or especially for centrally located tumors. So in those instances, I'll still adhere to these general guidelines in that I want to encompass the entirety of the tumor and treat all the T1 post-contrast enhancing lesion as well as the T2 flare hyperintense area. So sometimes those target volumes might be even larger, but that would include essentially all visible and clinical microscopic disease. So perhaps the target volume doesn't change so much as it's just going to still include the amount of disease, but it's going to be a larger burden of disease overall.
Okay, great. Thank you. And I think that another question we have when you're countering high-grade glioma is that the MRN is so, I think it's so important. Do you have a time frame to have that MRI done for the target volume delineation?
It's a great question because we know that these tumors can have a very high proliferation index and be very rapidly growing. And so even following a seemingly gross total resection, that burden of microscopic disease in many cases can recur quite quickly. And there's a few studies that have indicated that. So I think ideally we would want to get imaging within the nearest time frame to actually starting radiotherapy planning and delivery. In practicum, what that means, at least for our practice, is really to try to get imaging within about 2 weeks of initiation of radiotherapy, and especially for higher grade glioma disease. Now, in terms of when we're starting radiotherapy, for the most part, it's usually happening 4 to 6 weeks out from surgery because there needs to be time for surgical recovery and be outside a window for potential postoperative complications. In the idea that we're trying to treat these patients continuously once we start radiotherapy without a significant break in treatment, because that can have implications too for the efficacy of the radiotherapy if there is a pause and the overall outcome. So usually for patients, they may get immediate postoperative imaging as early as day 1 for us, after post-op day 1, after surgery. And if we can get them on treatment within about 4 weeks or so, even that, we still may try to get imaging at week 3 or so, or week 4 when we're starting our radiotherapy planning. Now, it's more resource intensive. It may not be available to everybody, but certainly if there's a patient who's 6 or 8 weeks out and hasn't started yet, and there was some residual disease left behind, I would highly encourage getting interval imaging at that point before starting treatment planning, because we can see significant regrowth of tumor during that time.
Okay, great. So go ahead, because I think we have questions from this. We're going to have a lot of questions from this slide, because we know that you have to make the decision whether you're going to use the ERTC or the RTOG. So I'll leave you to it.
Yeah, absolutely. And I know I got cut off during this time, but essentially for the ERTC, it's a single phase treating essentially all of the disease, residual enhancing disease to 60 gray. And then for NRG or RTOG, it's in two phases. The first phase, essentially treating the larger volume of contrast enhancing as well as flare hyperintense, but then a cone down or a boost after that, that's treating the last 14 gray to get to 60 gray to just the surgical cavity plus any residual enhancing tumor. Now, the interesting thing about this, and there's been other studies done by other institutions, is that these are all widely accepted, and the outcomes are essentially similar. So it doesn't appear that there's an inferiority, and that speaks, I think, to somewhat of the biology of the disease, or ultimately, the poor overall durable local control that we offer in this disease, and that's certainly borne forth studies that include hypofractionation to try to escalate dose. But in practice, both of these have been widely accepted and used, and there's really not one that I would say that any thought leader would necessarily favor, apart from thinking about the potential toxicity. And there are times that actually I would consider using the GIA approach, as I do favor ERTC to be more inclusive. If it's a very big target volume and there's questions about whether the edema represents actual surgical related edema and not T2 clinically microscopic disease, I might favor being a little bit more gentle with the dose schema and use the NRG or RTOG type approach. And I just wanted to point out, again, from that Zoom slide before, the Zoom poll, can see even among expert consensus papers, there's quite a variation, and some folks are opting, you can see here, to actually potentially overtreat to some degree. This is a CTV contour, and you can see how I would acknowledge, yes, in areas of disease where you can see something crossing the splenium of the corpus callosum, certainly that should be chased and included in CTV. But here, more posteriorly, you can see that there are some within the expert pool that were just allowing what is essentially an isotropic expansion of their GTV contour to allow for this to cross the falx into the occipital pole. And so again, even with folks who treat CNS malignancies almost exclusively, there's still some variation in how folks come and treat. And I would say, and maybe this is something that Dr. Lee had mentioned, I always favor over-treating if there's any question, because you don't want to undertreat. The volumes are so large to begin with, and you can see very rapid failures if you undertreat. So just to review, the standard chemoradiation regimen, as published by Roger Stupp, is 6 weeks of concurrent temozolomide or 30 sessions fractionated radiotherapy, and that is to 60 gray, and that's given with, again, daily concurrent temozolomide and body mass prescribed. And then after that, there's adjuvant temozolomide, generally for 6 months, as tolerated on a slightly different regimen or schedule of 5 days of therapy at double the dose every 28 days. So that was borne out in this phase 3 seminal randomized controlled trial, showing that the addition of temozolomide to radiotherapy improved overall survival. And it's important to note that the patterns of failure suggest that most of the failures still remain in field. About 2/3 or so of the failures are in field. So there's questions about the durability and the effectiveness of the dose as we use it today. And maybe there's room for additional hypofractionation. Now, it's also important to note that on subsequent analyses, it was recognized that the patients who were benefiting from the temozolomide seemed to be those who had methylation of the MGMT promoter within tumor specimens, and that's shown here in again a subsequent secondary analysis of these trials that included temozolomide, that in the presence of radiotherapy, temozolomide is really just benefiting overall survival, shown here in those folks who are MGMT methylated. So I'll move on as we want to get into the hypofractionated component of the talk, and we'll talk about the rationale for hypofractionation. So what, broadly speaking, again, this is, you've had a series of talks on hypofractionation. What's the utility? Well, it includes the fact that you can increase the biologic effective dose to overcome potential radiation resistance. So hypofractionation can be a form of dose escalation. And also, there is a logistics component to this, or a resource component of this, that it can shorten the length of treatment. Currently, these patients by conventional radiation are treated over 6 weeks, and that's a significant demand for both facility time as well as for patient time, especially in the setting of what is a very severe prognosis. So hypofractionation can shorten the length of treatment. Now, when we talk about hypofractionation in the context of high-grade gliomas, it's important that we're talking about slightly higher dose per fraction. That's in the order of maybe 2.5, 2.6 gray per fraction. There are some studies that have used doses that are a little bit higher on the order of 8 gray, but generally hypofractionation for high-grade glioma is not ablative dosing that's used for, say, lung or liver tumors. So it's not SBRT or SRS. There's a few studies that have invoked those techniques, but most of the time it's just slightly higher dose per fraction. The reason for that is the infiltrative nature of these tumors is that much of what you're treating in your target volume is healthy brain parenchyma, and that can put it at risk for toxicity. So it's important to recognize the challenges for hypofractionation within the treatment paradigms for high-grade gliomas, that the target volumes are large. They're often generally homogeneous in terms of how we're prescribing. So because of that, we're prescribing to higher isodose lines. You can generate very shallow and sizable dose gradients. So a fair amount of normal brain tissue will be included in the treatment plan. And that limits, I think, how much we can dose escalate. Now, there have been studies performed and meta-analyses that have demonstrated as you use larger fractions sizes, so 2.5 or higher gray per day, you see a significant increase in the risk of brain injury. And so that at the gate, I think, limits how much we can dose escalate these patients, because we really have to respect that therapeutic window and that threshold of maintaining good tumor control, but without the expense of causing undue brain toxicity. And we're talking about radiation necrosis, which in and of itself can be a devastating injury in terms of cognitive, motor, and sensory function. And it's important to maintain and champion the quality of life in these patients who already have a very limited prognosis. So when we talk about dose, we often are talking about biologic effective dose, recognizing that the actual dose and the biologic effect are not just a simple function of the total dose, as you've heard in your previous series, but also how much dose is given per fraction and some intrinsic property of the tissue that's being irradiated. And so I show here, as pertinent to brain treatments, some of the biologic effective dose considerations. And so if we look at in the first line there, 60 gray is given in 30 fractions, that may bestow a tumor BED of about 72 gray. But if you look at normal tissue, again, because of normal tissue with a lower alpha beta may be more sensitive, it can actually be more profound effect on normal tissue. Now, if you take that same dose of 60 gray and deliver it as 15 fractions, so half the time, you can see the tumor BED goes up about 15% or so. But the normal tissue goes up much more significantly in terms of the biologic potency, close to 50%. And so that's the challenge in this setting, is that you lose some of that therapeutic window when you hypofractionate and include a fair amount of normal healthy brain tissue. Now, we'll talk in just a moment about hypofractionated approaches, and some of them that are very well evidence-based include treating 40 gray or 40.05 gray in 15 fractions. You see there's a decrement in the potential tumor control, but at the same time, what you'll see is also very modest effect on normal tissue. So it's a little bit more gentle for normal tissue. Similarly, more modern hypofractionated approaches, including 25 gray and 5 fractions, further decreases the potential tumor biologic dose and potential effects on tumor control, but it's also more gentle on normal tissue BED. So I think the takeaway is that when we hypofractionate and include large volumes of normal tissue, you have to recognize that you may narrow that therapeutic window. So I think it begs the question then in our patients, where does hypofractionation have a role? Because it can increase the risk of tissue injury. And are there circumstances where that reduced biologic effective dose may be acceptable? And so certainly we see in clinic, there's patients who have poor performance status, patients who are older, and from some of the original recursive partition analyses on patients with high-grade glioma, we see that those patients with poorer KPS who might be older and more fragile, they have a poor outcome. And the standard 6-week regimen may not be superior to something that's more hypofractionated recognizing that these patients may have inevitably a poor outcome irrespective of the approach that's taken. And so there have been a number of studies that have been undertaken. One of the earlier, and this was done in the
temozolomide era. Okay, he says he's joining again. I did see a great question from German Chavez from Mexico. What do you think about the edema present in the diagnostic study that decreases with the use of steroids? Do you include that in the contour when merging the pre-surgical image, or do you only take into account the edema from the current study? We'll wait to see like what Dr. Braunstein has to say. My understanding though is that there's a difference between edema and tumor. And oftentimes on T2, signal that's related to tumor can look a lot like edema, whereas edema also lights up. So there's some clues that you can look up for imaging to tell the difference between the two. I think in a lot of contouring protocols, they say cover the edema, partly because they want to make sure that people aren't missing the tumor. So it's kind of simplified instructions, but when you get more nuanced, you actually can tell the difference between tumor-related signal versus edema. And so the way I would answer that question is I would contour the current extent of a T2 signal that is seen, because that is representing your tumor. But like I said, we can have Dr. Braunstein's explanation, which will probably be better than mine.
No, you did great. He did great. But I think he did said that he was more generous with his volumes. And I think that whenever there is uncertainty and that happens with edema, perhaps he includes it.
Mm-hmm. Yep. Yeah. When in doubt, include it. I believe Dr. Braunstein is
he's here.
Yeah.
Okay.
Hi, everybody.
Dr. Braunstein.
Hi. Dr. Braunstein, I think you can leave your video turned off if you want to, if you have any troubleshoot with your connection, perhaps that can help. And Ben was going through one of the questions we had from the participants. Ben, if you want to share with Dr. Braunstein.
Oh, sure. Yeah, it was a great question from German Chavez from Mexico, asking what do you think about edema that you see on a diagnostic MRI that decreases with the use of steroids? Do you include that edema in the contour when you're merging the pre-op imaging, or do you only take into account the edema from the current study?
That's a great question. And so I will often, again, use the preoperative imaging. Now, if the patient's been on any amount of corticosteroids at their initial preoperative imaging, and that changes and you see reduction, I may reduce that target volume accordingly. Sometimes, in fact, these patients often, when they're presenting, will come through with either non-contrast or contrast CT-based imaging, and I'll use that sometimes as what I would consider to be the baseline, and then look to see if there's been some reduction in that edematous volume from use of steroids. And if so, I would often be a little bit more conservative and not over-treat that edema. But again, I would maintain that if there's any question, I tend to over-treat than under-treat. Okay.
Great. And Dr. Braunstein, if the internet shuts off again, you can join on your phone if that has a better connection, and I can share the slides.
Thank you all. Yeah, again, I apologize for the internet connection. So we were talking about non-inferiority of doing hypofractionation at 2.67 gray per day in the pre-Temodor era. There was an update of this. Again, now these are patients, now this is in the post-Temodor era, but not patients who are receiving temozolomide. And these are patients who are considered frail by both age or performance status characteristics. Taking that 40 gray and 15 fraction, then further reducing it down to 25 gray and just 5 fractions. And you can see here also non-inferiority still associated with poor overall survivals of less than a year in this patient population, and somewhat limited in terms of the volume size of the targeting, especially with such a hypofractionated dose of 25 gray and 5 fractions. But as I showed you previously, the overall biologic dose to tumor, but biologic dose to normal tissue is reduced in this instance as compared to the conventional 60 gray and 30 fractions, or even 40 gray and 15 fractions. So even though it might seem somewhat contradictory, this is the use of hypofractionation really to escalate the intensity of therapy in these patients and try to preserve their time and potentially quality of life in folks that unfortunately appear to have a very poor prognosis due to their disease. Now, if you look at this Perry paper published in the New England Journal of Medicine, this was looking at patients incorporating temozolomide into the 40 gray and 15 fraction regimen. And you can see here, as was the case with the Stoop regimen, that the inclusion of temozolomide actually improved outcomes. And so these were patients, elderly patients of age 65 or greater, that in that cohort who seem medically fit to receive temozolomide, and again, this may be selectively in those patients also with GMT methylated tumors, there can be a role for inclusion of chemotherapy. Of course, there are consequences to the chemotherapy. There's potential for count reduction and in rare instances, aplastic anemia, as well as more pertinent, perhaps nausea and fatigue on the medications. But if patients seem physiologically robust, despite being older and it may be appropriate, we'll often offer temozolomide even with hypofractionated regimens. So, the other component, hypofractionation, is not just in the upfront setting for frail patients, but also in the recurrent setting. There's no standard of care for patients with recurrent high-grade glioma. The overall survival is poor. Again, the pattern of failure is often in field. So these are local failures. So we are retreating in previously treated fields. The treatment options can include interval surgery, change in systemic therapy, clinical trial, but also reirradiation. And the goal, of course, is to preserve quality of life, to try to give some durable local control for these patients. And in that regard, selection is important. And in general, just like the more fragile patients in the upfront setting, we often prefer shorter course radiotherapy regimens. And there's a number of cited clinical experiences using hypofractionated regimens. The text here is very small. I apologize for that. But most of the time, what's being employed are regimens of 5 to 15 fractions for these patients who've already been through conventional chemoradiation at some point. Again, patient selection is challenging. Here, my colleague, Dr. Shannon Fogg et al., had published what I think is a seminal paper in the US from patients previously treated on trials, looking at hypofractionated regimens on the order of about 35 gray as delivered as 10 fractions of 3.5 gray. And that has, EQD2, not a BED, but EQD2 about 45 gray. So they're receiving a sum total from all the radiation course, about 105 gray. And this showed, again, single arm, but retrospectively, median survival of about 10 to 12 months post-radiation. So many groups, both us in the US as well as in Europe, have looked at various reirradiation factors that can contribute to overall survival to try to select the patients who may actually benefit. And there's a number of prognostic indices that are used, looking at the patient's overall performance status, looking at the time from the initial radiation to the time of progression where we're considering reirradiation, also thinking about what the dose of reirradiation may be. And this at least allows us to prognosticate and have, I think, important informed conversations with both our interdisciplinary care team members, but also with the patients themselves about what are the expected outcomes with reirradiation, recognizing, at least in reported experiences, that the toxicity seems to be relatively limited in a setting of reirradiation with those modest hypofractionated doses. And so we continue to use reirradiation and continue to consider how to optimize this in our patients. But I think hypofractionated regimens remain a mainstay of approach in these patients. I want to talk about one other perspective on hypofractionation, which is for dose escalation. We're seeing more and more clinical trials that are using hypofractionation as a means to increase the overall biologic dose. And often this is based upon the reconsideration now in the post-temozolomide, because many of these studies that were done previously were done without temozolomide, and you saw some of those initial studies back in the 70s. but this notion of taking patients with newly diagnosed high-grade gliomas and then giving them, as part of their treatment, doses that include 75 gray to some subset of the volume, in this case, the T1 post-contrast enhancing component of the volume. So you're giving that at a dose of 2.5 gray per fraction over 30 fractions. Now, Dr. Gandhi, who reported this at Astro in 2020, initially found that there was no superior outcome using dose-intensified approaches, at least with photon-based dose-intensified approaches, unfortunately. So even in the temozolomide era, this didn't seem to improve overall outcomes. However, I think importantly, it didn't show any worsening of treatment-related toxicity. So at least it's established that with modest target volumes of limited size that are going to dose escalated hypofractionated doses, that it appears to be safe. And I will say that there have been a number of other smaller institutional studies using various forms of biologic guided or multiparametric MRI imaging to identify areas at highest risk of maybe greatest burden of disease using hypofractionated approaches that actually showed some positive signal and are very encouraging, perhaps to consider for larger exploration in a bigger patient cohort. Now, I also wanted to point out there's a few examples of what I would consider to be extreme hypofractionation for high-grade glioma, and that includes patients such as those treated in this trial where they're receiving stereotactic type doses for limited volume. And at least in this early phase trial by the group at Stanford, they were able to show, if anything, that there was relatively low rates of radionecrosis, about 30% low-grade radionecrosis, with median survival about 15 months in these patients, with a median planning target volume about 60 cc. So there may be some patients where we can use extreme hypofractionation in the upfront setting. And I think this continues to be an area that's worth exploring, again, thinking about the prognosis of these patients and getting them, bridging them to other therapies and clinical trials. I'll take a quick pause there and then just move on to some technical considerations. Any questions thus far?
Great. Yes, I think we have a few questions from the audience that I would like to go through. And I know that you're going to go through some clinical cases, and I know that's going to be a point where we're going to be answering a lot of questions. But the first one is from the Gandhi study, because there is a question from Andres Rodriguez. Was there any difference from the dose escalation by the MGMT status in the Gandhi trial? You just show of dose and intensified treatment?
Yes, in fact, there was a very, I think, provocative finding that I didn't show here, which was the patients, at least in their initial examination, the patients with MGMT methylation may have done slightly worse, actually, with this dose escalation. So again, very provocative, maybe not, fully initially understandable, but there is some concern that warrants, I think, again, further scrutiny of that study, that the outcomes appear to be slightly worse in that cohort, that we'd expect them to do better.
Okay, great, thank you. And I think that this is a key question for this talk, is that how do you make your decision to treat someone with a hypofractionation regimen in the upfront setting? What is your definition of that frail patient? Are you using the ECOG status? Are you based on age? Is there any other factor that you use to make a decision when to use a hypofractionated regimen?
That's a great question. And I think that we have two considerations, one of which is the data. And the data, again, in these highly selected patient cohorts, definitely supports hypofractionation in elderly patients, irrespective of performance status. However, I think in practicum, I think many of us have biases towards doing the more protracted fractionation, the standard of care, 60 gray. And I think when you look at individual experiences, institutional experiences, those regimens often actually have shown some better outcomes when we treat with more protracted fractionation. So generally, I just look at patients that it's mostly driven by performance status, not physiologic age, or sorry, not chronologic age. So patients who have really poor performance status, where I think we would prognosticate, because performance status, I think more so than anything else, drives outcome when you look at recursive partition analyses. So patients with really poor performance status, unlikely to recover, trying to minimize the burden of medical care in that cohort. That's the patient population I feel most confident about hypofractionating currently. But I think as we collect more data and overcome some of these biases and show that there's safety with hypofractionation, maybe we'll improve that overall pool and the candidacy. But I think we just recognize that there's probably some practitioner institutional biases with our approaches. Okay. So when we think about the protocol for hypofractionation, we're thinking about this in the same way we think about the protocol for anyone, any new technique. Patient selection is very important. Imaging is critically important. Mobilization, target delineation, constraints, heterogeneity, having a robust QA program, and then of course thinking about the patients, how they're going to respond to these approaches. And there's, I think of note, these protocols are freely available. This shows the Perry-based protocol for the 40 gray and 15 fractions with temozolomide. We don't have to necessarily design these de novo. We do have the protocols that have been put forth as part of clinical study that are freely available. And that's what I would encourage folks to utilize, because they're very specific about parameters and even about technical parameters, about beam angles, heterogeneity considerations and corrections. So that's what I would encourage folks to consider and review as you're implementing these hypofractionation regimens. So give a quick poll just to talk about something around treatment planning. What is your optic nerve constraint that you would think reasonable for a patient receiving 40 gray and 15 fractions for a high-grade glioma where the tumor is in proximity to the nerve?
So I'm going to launch the simple question. I believe this is a hard one.
I like to have these questions just to provoke thought.
If you have any problem with your simple, just send your answer through the chat. Almost 50% of the participants have answered. If you want me to share the results now.
Sure, that would be great.
Great.
There we go. So you can see this. Good. A great mix of responses again. I really like seeing that. So I'll go here. So the answer here, I think, is 42 gray. And the reason for that is when you're treating in 15 fractions, and I've shown you this data, I'll talk about it again. When we treat conventionally fractionated, 54 gray, I think is largely accepted as the standard 54 to 55 optic pathway constraint to minimize the risk of optic pathway impairment and neuropathy, myelopathy. But when we're using these more hypofractionated approaches, we have to adjust that. 54 gray that was delivered in 15 fractions would be fairly aggressive as compared to delivered in 30 fractions. Now, these other choices here, the 12 gray and 25 gray, those are relatively low. And if you have a tumor that's in proximity to the optic pathway, you don't want to underdose that tumor irresponsibly. And so you'll see that 42 gray is roughly equivalent to 54 gray that's conventionally fractionated when you're doing hypofractionation. And I'll show you a slide on this in a moment. And here it is that if you look at this information showing the likelihood of radiation-induced optic neuropathy, looking at conventionally versus hypofractionated approaches, again, here as a function of dose per fraction, you can see very nicely on this model curve that as a function of dose per fraction, the total dose at which you could potentially experience optic neuropathy is essentially decreasing. So as you increase total dose per fraction, the total dose at which you may be at risk for optic neuropathy decreases significantly. So you look at conventional fractionation at 2 gray per fraction, that risk is around, again, 54 to 60. That's, where we're looking at a risk of a few percentages. But as you increase, say, to like 2.67, when you're delivering 40 gray and 15 fractions, you can see that's dropping down to about 40, 42 gray or so. And if you go to very high dose per fraction, say, 8 gray per fraction or so, then, we're looking at something that's on the order of about, 20 or so gray. So you need to bear this in mind to adjust your organ at risk constraints as you're employing hypofractionated approaches, that we cannot use conventional fractionation constraints. And then again, unlike ablative radiotherapy for the heterogeneity, we're trying to limit in the hypofractionated setting for high-grade glioma. So another thing to consider is patients on treatment in terms of how they're responding. Recognize that when we hypofractionate, it's possible, because we're giving higher dose per fraction, that the patients may manifest a higher intensity and temporality of some of the acute toxicity. It depends upon the nature of the toxicity, but just from general principles, the amount of inflammation that can be caused, regional brain inflammation from hypofractionated approaches, may be more significant. And that means that for these patients that you have selected who have poor performance status and maybe have significant impairment due to their tumor burden or surgery, when you're delivering radiation to that region, more likely than not, if you're trying to predict the side effects acutely, they're probably going to be side effects that recapitulate what the tumor was causing. So if you have a tumor, say, in your motor region, and it has a partial resection, and then you treat that area, as you cause regional acute brain inflammation, you'll probably worsen symptoms that are motor related. So I think it's important when you're giving a higher intensity of treatments, at least acutely, that these patients are very closely monitored and that you have a good handle on supportive care interventions, including corticosteroids, caregiver education, and in some cases, maybe even upfront shunting if you're worried that inflammation is going to cause obstruction of CSF flow. So I think it's important as physicians that we are very tuned into the potential acute toxicities caused by hypofractionation. Okay, so now I'll just move on the last few moments of some example cases. So here's case one. This is a patient who's 81 years old, has new onset expressive aphasia, dysphagia, right facial weakness, and has a KPS of 60, multiple medical comorbidities. And here's their presentation imaging. Here's just the post-SCAD presentation. So you can see contrast enhancing multifocal lesions that are present here in the right frontotemporal region, insular region, maybe more clearly demonstrated on the T2 flare. You can see a lot of fullness here, compression of the ventricle in this area, in insular area, and the patient undergoes biopsy, and the pathology consistent with an IDH1 wild type glioblastoma. So here, another question, mostly just for a discussion and provocation here is what would be your treatment approach for this patient if you were treating this patient in your clinic? And this somewhat speaks to me the discussion that was put forth before about the variety of options, and when do you decide to hypofractionate?
Yes, awesome. So we're going to see the answers.
And there's also some great questions cooking in the chat that I think we'll get to that have to do with the specifics of contouring and treatment planning. So I think the cases will be a great way to go through some things.
50% of the participants have answered. We're going to just wait for a few more seconds to see the answers. Okay.
Let's wait 10 minutes, Maria.
10 minutes.
Okay, I think we're ready.
I think we're ready.
All right, so hopefully everyone can see this. So again, I love this, a really nice mix. I think I probably influenced or biased some of you presenting that evidence-based data for those, and certainly that's reasonable, but all of these are reasonable. I want to point that out. And I think all of them may be used in practice, and all of them, even in this sort of patient-specific situation, we talked about some of the comorbidities for this patient, but I think this really is all of these are supported by the evidence base. I didn't present, of course, all the litany of trials, but certainly there are patients who are treated to 30 to 34 gray and 10 fractions without chemotherapy, and that's supported by the evidence in this group. But it's really an individualized decision. For someone with these characteristics, I think that the outcomes, again, are somewhat guarded. We've seen, poor prognosis in a patient who's elderly and has a poor KPS. So I think it warrants discussion with your interdisciplinary team and a discussion with the patient as well. Okay, so In this case, this is a patient that I treated. I chose to treat in 40 gray and 15 fractions with concurrent temozolomide. The volumes that I used included just a single stage, so T1 post-GAD plus T2 hyperintense, and then a somewhat selective 1.5 centimeter expansion to CTV that relatively respects anatomic barrier. So you can see I'm not really taking the volume across the contralateral side here. I use a 6 MeV VMAT, and the brainstem Dmax that I used here was 42 gray. And just showing you, I showed you this for the optic pathway. Now just showing you again, for the BED, 54 gray, which is what I would use for conventional fractionation as a brainstem constraint for a high volume of brainstem. Has a normal tissue BED using alpha beta of 2, again, being conservative, is about 103. And 42 gray is in close proximity to that. So, and again, if you're treating to 40 gray and 15 fractions, trying to keep this homogeneous, 42 gray would represent, 105% heterogeneity with a hotspot. So it should be relatively achievable in these instances. Now, of course, I'm showing you a single axial section, so you don't necessarily appreciate how far inferior this extends, but there is some encroachment upon the upper pons and brainstem. And so this is how I approach thinking about the constraints. Of course, these constraints are also often included in the protocols. So you can look at those guidelines for these hypofractionated cases. So that's case 1. I'll move on to case 2, unless there's any questions about this case.
There was one question earlier in the chat that says, if you're doing moderate hypofractionation like this, do you contour differently compared to if you were treating with conventional fractionation?
So in general, no, I still use the same margins. On some protocols for those more significantly hypofractionated, the margins might be a little bit more compact. And in some cases, just use the T1 post-contrast enhancement. I think you're at risk for under-treating disease in that instance. But again, I try to keep the target for 40 gray and 15 fractions. I'm pretty permissive, but if I were to treat in 25 gray and 5 fractions, I try to keep the target volume less than 60 cc's. Due to other studies that have shown potential for increased toxicity with that. And there's data that actually lends itself more so from the brain metastasis literature and using short course fractionation, 5 fractions, that suggests that when you get into larger target volumes above 20 gray or 24 gray, you may increase the risk for radiation injury. So I try to be conservative. Again, practicing from the principle of do no harm.
Mm-hmm. And then there's another question that I think is illustrated here, but if the lesion's in contact with or like abutting the ventricle, should you expand the CTV to include the ventricle, or can you exclude that zone?
Great question, because the ventricle tends to be a little bit more sensitive, especially in the ependymal area. So I usually include the ventricle, but I won't include the contralateral component of that. And I won't extend along all of the ependymal surface unless there's diffuse gliomatosis. Then I would be more comprehensive. But in general, no, I would respect the major anatomic boundary into the CSF, but I'd include certainly the ependymal surface of that ventricle.
We'll do more questions later.
Okay, so here's a case. This is in the rear radiation setting. It's a 53-year-old, had seizures, and this is the upfront setting, had MRI that demonstrated a right temporal lobe lesion, had a subtotal resection. The path again showed what would be considered a molecular glioblastoma, IDH wild type, MGMT unmethylated. This patient underwent conventional chemoradiation with 60 gray and 30 fractions IMRT with temozolomide. You can see even in this upfront setting, in terms of the dose distribution, that I'm decreasing that 60 gray into the upper pons, into the brainstem. But then 2 years later, had what was a distant recurrence. Now, this is less common than the infield recurrence, but you can see a distant recurrence with a T2 hyperintensity around the 4th ventricle. And in this case, we did rear radiation, 35 gray and 10 fractions, and kept the brainstem Dmax less than 30 gray, which fits with trying to minimize harm to the brainstem in this setting.
Dr. Braunstein,
One other thing
we have a question here. I'm sorry, Ben. We have a good question here. Is how much time do you have to wait to consider a re-irradiation? I mean, we know that we're handling a very bad prognosis disease, so the recurrence time might not be as long as other disease sites. So how much time do you wait to consider a re-irradiation?
Yeah, I think there's no clear rule here, but prognostically in the nomograms, a rough rule of thumb is about a year, especially in the setting of an infield recurrence. Because if there's an infield recurrence less than that, it says that the disease is so radiation resistant that probably additional radiation isn't going to offer much benefit, I think, practically speaking. But much of the nomograms would say about a year is a minimum, especially for an infield recurrence. Now, of course, if you undertreat it and there's a regional recurrence in a few months in an area that didn't get high dose, I would consider to do something with radiation to that regional recurrence. But for a true infield recurrence, I would probably wait at least a year. And the other thing is, how do we define these recurrences? Sometimes they're very difficult to distinguish real progression from pseudo progression radiographically. Now, it's different if a patient undergoes an interval surgical procedure and you have path that shows that there's active tumor. But usually we would follow these patients closely with imaging every 2 to 3 months. And if we see concern for progression, we're, I would say, thoughtful, but not too quick to act. And so we might get another short course imaging to try to distinguish true progression from pseudo progression before offering re-irradiation to these patients. So again, I think a rule of thumb is about a year, but it needs to be individualized until we have better data. Okay, so I have a third case, which is hypofractionation for a diffuse midline glioma in a pediatric patient. This is a 4-year-old girl. She presents with ataxia, dysconjugate gaze, dysphagia, nausea, and vomiting. You can see on T2 imaging, there's a fairly expansile lesion in the midbrain in the pons. You can appreciate it here in sagittal imaging as well, really filling the pontine component of the brain. And in T1 postgadolinium, there's hypointensity. So this may not represent such a high-grade lesion, but that's not uncommon for these diffuse midline gliomas, that they still are, per WHO 2021 criteria, higher grade disease, but they may not show contrast enhancement. And also this patient had evidence of hydrocephalus at presentation, shown here on an axial scan, due to CSF flow obstruction, which also is not uncommon. So this patient was shunted, first and foremost, to manage her acute issues and had some symptomatic improvement, had a biopsy, and the pathology, not all these patients are biopsy, radiographic criteria can be sufficient, and certainly there's some risk associated with biopsy in some instances. Nevertheless, this patient underwent biopsy, and this showed an H3K27M diffuse midline glioma. And this, again, per WHO classification, is within the realm of high-grade gliomas. And the treatment approach, I would say standard conventional historical, is radiation alone, which is 54 gray and 30 fractions. And you treat the T2 hyperintense component, if there's a T1 as well, post-GAD, with a 1 to 1.5 centimeter margin. And unfortunately, the prognosis for these patients is fairly grim at about 9 to 12 months. Now, there's been some provocative data coming up from a number of folks internationally, including this randomized control trial that was performed in Egypt, 54 gray and 30 fractions versus 39 gray and 13 fractions. So hypofractionation at 3 gray per fraction. You can see there's a small decrease in overall biologic effective dose, but at least in this, I think, well-run randomized control trial, there was a non-significant difference in progression-free survival or overall survival. Now, in terms of absolute number, maybe there was a slight increase or benefit for conventional fractionation, but still there was non-inferiority demonstrated in this trial. And so, the conclusion for many of us who treat these pediatric patients with diffuse midline gliomas, that there's comparable outcomes, and that may justify a decrease in the time of course to be able to treat these patients in just 2.5 weeks rather than 6 weeks for, again, patients who have poor prognosis, who may go on to clinical trial thereafter. So this is the patient as I treated the patient, again, kept in 13 fractions, the brainstem Dmax less than 42 gray. So this is 13 fraction regimen out of 15, but still kept that Dmax less than 42 gray, the cochlear mean less than 30 gray. Patient had minimal skin toxicity from this and had some symptomatic improvement within a few weeks of radiotherapy, was able to decrease dose of corticosteroids, and had a durable response over several months. So just to wrap up here, before I take some more questions, we talk about a summary here. I've gone through the W's, why to hypofractionate, and that includes shorter courses. In many instances, show non-inferior outcomes. It can be very patient-centered with fewer visits for these patients. It might be better resource allocation, depending upon your capacity locally. There may be some biologic potency with hypofractionation. I think we're going to see more and more of this with these newer image-guided studies. Certainly, you'll see this coming out at major society meetings where maybe selectively dose-escalated hypofractionation can have a benefit. Also, we can get patients through radiation more quickly, not just for their own well-being, but to get them to their next therapies. And in this very fragile patient population, clinical trials may be paramount. And so if we can get them to a new trial that may offer something additional, I think there's benefit to that. So who can benefit? We've seen older, more frail patients, but also younger patients with the diffuse midline gliomas. Patients, again, with poor performance status, with logistical challenges for getting to the radiation therapy centers. I didn't talk much about it, but patients with fairly small discrete lesions, there may be a role for more ablative techniques. You saw some extreme hypofractionation examples for patients who are getting reirradiation, and overall patients with poor prognosis. And the question is maybe everybody. I don't think we know. We haven't run those studies really in the post-temozolomide era, that maybe we can hypofractionate even slightly these patients to reduce their burden of time in the treatment center. So what do you need? You need definitely a strong interdisciplinary team and communication, because treatment of high-grade glioma still remains interdisciplinary, including surgery, oncology, and radiation oncology. And so I think it's very important for everyone to be informed and feel confident about the treatment approach. We talked about timely post-surgical imaging for target delineation, which can be very complex and difficult to reach consensus. Proper mobilization. Hypofractionation specific dose constraints are also important from a safety perspective, robust QA, and of course, daily image guidance. Now, as compared to, say, thoracoabdominal tumors, lung and liver, the cranium is a fixed space. We don't have to worry about motion management as much, but it's still very good daily image guidance, I think, is paramount. So with that, I'll thank you and happy to take additional questions, and I'll put on my video at risk for Wi-Fi disaster one more time. Thank you, everybody. Any questions? I think we had a very great discussion. I think folks are very appreciative of some of the challenges and nuances in treatment of these tumors, both in terms of target delineation as well as patient selection. And I think that's something that we deal with every day with each patient. It is very much individualized.
Thank you so much, Dr. Braunstein. That was an amazing session. As you mentioned, I think that we went through a lot of questions that we had from the audience. I want to ask if any participant is interested in asking the question and talking. That's perfect. You can ask directly to Dr. Braunstein. So I think this question came by a few times, and is, do you make any decision based on the IDH or the MGMT status right now?
I do. Well, in terms of, I don't, although I will say prognostically, I do. I think patients with H mutant tumors who otherwise may be elderly, again, maybe a slight bias on treating with conventional fractionation. I said how I think performance status drives outcome more so than anything else. Certainly that's evidence-based. For these patients, an elderly patient who has a good performance status, who otherwise has an IDH mutant tumor, I might slightly favor conventional fractionation in those patients. I think, but otherwise, again, I think mostly performance status and maybe age is driving the nuances of the treatment recommendation. It doesn't change my dose at this point.
Do you always use for hypofractionation the 40 gray schedule? Because someone asked you if you've seen this schedule that's 60 gray in 20 sessions. So if you've used it, they mentioned an astro presentation in 2021 that used the schedule in 60 gray. So what do you think about this regimen, and do you ever use it?
That's a great question. So the answer is yes. And I think it speaks to the fact that, there are a number of published, and that was published, I think, that's really well evidence-based, a really well run study. I do use that on occasion. And again, you see this continuum. You have everything from 60 gray and 30 fractions, to 60 and 20, to 40 and 15, to 25 and 5, and now maybe even, something like 30 to 40 and 5 that I think are well tested and well evidence-based. I think the question is, for using, let's say, six, when we're talking about maybe conventional or hypofractionated everybody, I think maybe we'll move towards something like that first for everybody. But often the patients that I am hypofractionating, I'm doing it because they maybe represent a more extreme case where they have a poor prognosis, and I'm really trying to minimize as much as possible. So, again, I think being very transparent, having trained mostly in the 60 and 30 era, and in the 40 and 15, I'm more comfortable with those doses. That's informed by my personal experience, which is not a great way to practice medicine always. But these newer regimens, including the 60 and 20 and 25 and 5, I think you'll see our community adopting them over time because the outcomes are just as good.
Yes, and I think that this is a message I think that we've learned from this curriculum, is that if you're going to start using a hypofractionated regimen, save your data, follow your patients, and start seeing how it works for you, right? So I think that as a great advice from you is just to keep learning from your experience on how your patients responded to a certain treatment.
And I would add one other thing to that, is that also respect the fact that these patients treated on trial are usually highly selected, and they're treated, with very structured regimens, with very close observation. And you should always ask yourself, is the patient that I'm seeing in front of me, do they fit with the criteria and the type of patients treated on trial? I think that's critical.
Totally. Thank you so much. So there's another question we had, I think, a few times, is that do you ever use a simultaneous integrated boost for high-grade gliomas?
It's a great question. And this comes down to, I think, really, despite widespread presentation in the literature about perhaps, what is the role for extensive surgical resection in these patients? And there's certainly evidence, and I think there's bias in my institution, and some evidence-based, frankly, that patients do better with more extensive resections. I think that's a fair consensus in the literature when they're done safely. And so as a radiation oncologist, I'm often asking, can I overcome what might be a subtotal resection and gross residual disease with radiotherapy and dose escalation? So I will share that in some cases, and again, this is not on necessarily clinical trial, I will slightly hypofractionate and dose escalate patients with a simultaneous integrated boost who have a fair amount of gross residual disease. I won't do it necessarily in a way where I'm putting normal tissue at risk, but if you have, let's say, a cortical peripheral based tumor that's well lateralized with a very clear amount of gross residual disease, I may slightly hypofractionate to the regimens that have been used on the NRG trial to use like 75 gray in 30 fractions. Because at least I feel good about the toxicity profile from that. And so I can't say for sure that there's a benefit, but at least in terms of toxicity, I feel confident that I'm not going to hurt the patient.
Okay, really important.
Great. If I may, there's a great question from Alejandro Rodriguez. If a recurrence occurs distally, like outside of the original treatment field, why not use the 60 gray and 30 fraction scheme?
Great question. And I gave you an example of that where I actually hypofractionated that patient. I think it's safe. I think it's effective. I think the challenge that we see, at least on the data that I've reviewed for reirradiation, is that when you have distant progression, we talked about, indications for hypofractionation. If you have distant progression within short order, so like a patient who presents who has high-grade disease and then presents with a distant recurrence, let's say within a year, although I didn't talk about that in terms of prognostic nomograms, that patient still has a poor prognosis. That patient likely, in terms of future failure, will fail distally again within a few months or a year. So I think it would be reasonable, and I've had patients who've been treated with, say, high-grade glioma patients, maybe grade 3, who've survived 5 years and then had a distant recurrence, and I've gone back, that's also high-grade, and treated exactly like that with conventional fractionation, high-grade, because I think their biology reflects maybe someone who might have a reasonable prognosis. But for most patients who recur in short order, I'd say within a year, I still consider that someone who may benefit from a shorter course. Again, it's a discussion with the patient just in terms of giving them less time within the medical facility and more time to enjoy a quality of life. But there's not a right answer.
And then maybe one more, any difference with hypofractionation in patients on bevacizumab?
Oh, that's a great question. So, we have some data, frankly, from NRG that suggests that radiation plus bevacizumab, certainly better than bevacizumab alone. And, we recognize that the patients on bevacizumab or Avastin, it does have some effects to mitigate the inflammation. So I didn't talk about it, but many of these patients actually do support using concurrent bevacizumab, even more so than corticosteroids, for hypofractionation with dose escalation. We can see somewhat reduced acute inflammation and acute toxicity. So I think there is a role. Again, it's, if a patient is an appropriate candidate, no contraindications, we certainly do consider bevacizumab. Very frequently in the recurrent setting, I can't say that we're doing that so much in the upfront setting right now, but if there's a fair amount of inflammation, certainly I've done it for patients with poor performance status in the upfront setting.
Entonces, muchas gracias a todos los participantes. Dr. Braunstein, have a great day.
Thank you all.